Thank you for joining today's Health Education and Learning Program webinar, RHC's Performance and Quality Improvement. By attending this webinar, participants will be able to describe current RHC requirements from the RHC conditions of participation related to performance measurements and quality improvement, define the relationship between quality and payment for primary care providers, and gain an understanding of national initiatives currently in place and how they impact RHCs. And you will also be able to identify activities to consider when developing and administering program evaluation and other performance measurements and quality improvement programs. With that being shared, I'd like to welcome our guest speaker, Tani McCoy. She was raised and still resides in rural Idaho. She's earned her MS in Psychology Science from Shippensburg University, currently pursuing her doctoral work in experimental psychology with a focus on rural health at Idaho State University. Tani serves as the Idaho Bureau of Rural Health and Primary Care for the last 6 years, 2 of those years as a primary care research analyst in the primary care office, and 4 of those as the State Office of Rural Health Program Manager. Tani holds certified rural health clinic professionals credentials, as well as Lean Six Sigma Green Belt status. Tani specializes in RHC programs and compliance, as well as data analysis. Thank you for joining us, Tani, and I will now turn it over to you.
Thank you so much, Kiona. Hello, everybody. Again, I am Tani McCoy. This is me. This is who I am. I never use my camera because I live in rural and it completely bogs down my broadband. So I hope you guys understand. But just for getting to know each other's sake, here's what I look like. So I am the Technical Assistance Manager for NOSOR. That is the National Organization of State Offices of Rural Health. We are the membership organization for them. We are here to serve them and their rural stakeholders by helping leadership development, advocacy, education, and partnerships. There is, in fact, a State Office of Rural Health in every state. If you would like to find information on yours, please feel free to go to our website and you'll be able to search them up and find their contact information. SOAR, the State Office of Rural Health, is a federal grant program from the Health Resources and Services Administration, HRSA. The 3 main charges of SOAR are information dissemination, rural health coordination, and technical assistance. They are amazing resources for what is happening in rural health in each of your states, and I highly recommend getting to know and seeing if you have any potential future partnerships that you can pursue. Now for today, we just heard our learning objectives, so I won't reiterate them. But I just want to make sure that we emphasize that this is going to be a journey. It has been a journey. And at the end of today's presentation, I will pause and we'll be able to connect all the dots. So just buckle in for today and we'll make sure that we have a good understanding. Before we get going, always a reminder, documentation is the cornerstone of the business. So it's not just important for coding and billing, which of course it is extremely important for coding and billing, but documentation is everything. At the risk of sounding like my teenage niece, it is everything. Documentation is data, and data helps inform all business decisions, all patient care decisions. If you're like me, really nerdy, most life decisions are based on data. And it's anything that can be observed, anything that can be written down, counted. Documentation is everything. So again, what's the big deal about data? So glad you asked. How do we know that a patient is able to control a disease with a newly prescribed medication? Do we just ask the patient, hey, do you feel better? They say yes, and we call it a day. No, we have to look at all of the supporting evidence that is gathered. So of course, we ask for that patient feedback. We ask them how they feel, have they noticed a difference? But we also perform a physical exam. We run blood work. And if we can, we compare current findings with benchmarked initial findings. Practicing medicine is a science, and data is the language of science.
Alrighty, so I apologize for skipping out on the audio. I will just reiterate a couple points. It's important to note that it's not all about clinical data. When we're talking about data, it can be anything that we can observe or count, measure, etc. And very importantly, as part of their conditions for participation, rural health clinics are required to review their entire program, their entire business every other year. The technical term is biannually, but that's a weird word and I've only heard it since they changed the requirement. So I just go with every other year. And then also, all rural health clinics are required to have an emergency preparedness program, and they are required to review it every 2 years. And so these two program components are data-driven, data-focused, and are your performance measurements. Also your quality improvement program, if you choose to look at it that way. Please don't be scared of this. I will walk you through everything here. So again, conditions of participation for rural health clinics, specifically 42 CFR 491.11 is the program evaluation portion of the requirements. So this is actually written in law that a rural health clinic must comply with. It's broken down by A, B, and C, and D as well. And it outlines for you exactly what you must do. First up here is the clinic or center carries out or arranges for a biennial. That's that golden word right there. That basically just means every other year evaluation of its total program. And so that is very important to understand. You need to look at every single aspect of the business of the rural health clinic. And so basically from the parking lot to the staff, to the way you operate day to day, excuse me, to the way that patients are taken care of, to every single service line in your business, and even janitorial services. Every single thing needs to be looked at every other year in an RHC. Even if the RHC is owned by a hospital or owned by some sort of system, they can own 10 other RHCs, but they must perform a total program review every other year for every single RHC. So it doesn't matter if they're part of a system, they are looked at as an independent business when it comes to reviewing that physical plant's program. Here I have at the bottom of the slide live links for you to check out. I'm really big on resources, and if you tell me that it's free, I say sold. So here are some free templates for you to have a checklist of everything you need to look at to review your RHC program. And then also over here, here is a full template for a program evaluation. So when you get those slides, please feel free to check those out. Also that there are more resources out there. Google is your friend. And so please feel free to start investigating interwebs and see what you can find out Also, if you would like more information, you can always contact NOSOR. My contact information will be at the end of this presentation. Happy to help. Also, just a shameless plug, there are 50 state offices of rural health. And so if you would like to contact your state office of rural health, please feel free to get their information off of our website, again, at the beginning of the slide deck. They're always willing to help you. They're happy to help you. So there's help out there for anything and everything you need. You just have to know where to find it. And a good stop for the first place is with us. But I digress. Back to the content here. Your evaluation. Again, a soup to nuts approach, top down, bottom up review of anything and everything within your facility. Now, some important notes is that when you are looking at your biannual program evaluation, part of the requirements is that you have your medical director, your employed, so W-2 employed NP or PA, so that's a nurse practitioner or a physician assistant, and then an outside person that does not work at the clinic. It's preferred that they are a professional and so they know what they're talking about when it comes to the services that are provided at the rural health clinic. But honestly, they don't need to be because it doesn't specify in the statute, in the CFR. And so you must have those 3 people evaluating all of your policies. And so you need to document that that is occurring, and they must be present during those conversations about the policies. They must sign off on all of your policies. And so I always make sure to specifically point that out. Now, when we go through and we are evaluating all of the programs, all aspects of your RHC program, these are all based on data. A lot of these could be checklists. For example, like I have the example template here, but it's all data that needs to be evaluated. And so let's pick here a representative sample of both active and closed clinical records. And so as another part of the RHC program requirements, each year your providers need to be reviewing open and closed clinical records. Whatever your policy says that you're going to be reviewing is what you will be held to by a surveyor. They have recommendations and guidance, but it does not specify in the statute. So each clinic can decide what is a representative sample of your patient load. And so if that is 10 records per quarter per provider, if that's 50 records per year per provider, it doesn't matter as long as it is in your policy and you go by your policy. And so you need to have a mechanism in place to capture that data to make sure that you are going through with what you say that you're going to do based on your policies. And so that is a part of your program evaluation, is are you doing what you're saying that you're supposed to be doing? Now in this, there are other aspects to it, but this is what we're going to focus on for now. Just know that you need to be able to go back to your policies and see if you're following through with what you're doing. And whatever your policies say that you're doing, you have a mechanism in place to collect the data to be able to document and show a surveyor that you are following your policies. And again, there's a dime a dozen templates out there, but the one that I provided a link to down here is pretty good. And it has all the sections in there for you to be able to maintain your documentation. Now here, I'm specifying emergency preparedness because it is quite the behemoth. So after Hurricane Katrina hit New Orleans in 2005, emergency preparedness was added to pretty much all of the Centers for Medicare and Medicaid Services, CMS, programs. And the RHC certification is a CMS certification. And so now they are required to have a robust emergency preparedness program as part of their overall operations. And so the specifics will be in 42 CFR 491.12. And I have a hot link up there for you. It's a pretty beefy section, so I wasn't able to copy and paste it all here, but I have the headers for each section. And so that is your emergency plan, your policies and procedures, your communication plan, training and testing. And then here, if you have an integrated healthcare system, and so for example, you are owned by another agency or entity like a hospital or a skilled nursing facility, and you are incorporated into their emergency preparedness plan, then you have extra requirements. A lot of rural health clinics opt to have their own emergency preparedness plan, especially if they are not physically connected to the, usually it's a critical access hospital or a certified nursing, skilled nursing facility. So you could be on the same campus and have your very own emergency preparedness plan. You can even be attached, located within the same building, and have your own emergency preparedness plan if you are a rural health clinic. And so I encourage you to explore that if that is something that you're interested in. Again, hot link up here. On the right here, I have a hot link for a template. Again, huge fan of free resources and templates where you're able to plug and play your individual information. So with this emergency preparedness operations plan, it is a pretty good, robust template where it walks you through all the different requirements that you have to hit for this, for emergency preparedness. Now, there are several steps that you have to go through to be able to complete this. You have to have your own all hazards approach, risk assessment, and whether you are attached or incorporated into an integrated healthcare systems emergency preparedness plan, each individual rural health clinic must have their own risk assessment, whether they are in somebody else's program or not. That's very important. And in that all hazards approach risk assessment, it is a very detailed review of your local data. And so you have to go through, and I'm sure I'm speaking to the choir here, but you have to go through and understand the data of your local community. What are the hazards that could affect your practice? So that is, what kind of natural disasters do you have to prepare for? Are you in a location that you're going to be hit by a hurricane? Are you in a location where tornadoes are frequent? I'm in Idaho, and so there's a real possibility that a wildfire is going to be coming through. If not the fire itself, the smoke from the fire. There's blizzards, there's a pandemic that you can prepare for now. And we've learned a lot of lessons. And so it's just a step back look at the forest for the trees of anything and everything that could upset the operations of your rural health clinic. And again, this is all data. This is part of your program. This is a requirement in law that you have to evaluate. And so it's very important that you have a really robust emergency preparedness operation plan. And this is all data-based, and this is all Every 2 years, you can benchmark, you can evaluate, you can see trends. And we'll talk more about that in a second. Another part of this is your policies and procedures. You have to have specific policies and procedures for emergency preparedness. And again, whatever your team of your medical director, your W-2'd either NP or PA, and your outside person on your team of policy and procedure reviewers, whatever they say is what you have to abide by and what you will be held to by your surveyor. I keep emphasizing that because it's very important that you follow what you say you're going to do. Now, the communication plan is very robust, and this is something that really should be looked at more than every 2 years. This should be a part of your regular program evaluation, not just for emergency preparedness. But this is basically your phone tree of who is all connected to your rural health clinic. So the staff, the providers, the patients, the patient's emergency contacts, who's going to be contacted when and how. In this requirement, you need to have a backup version. And so are you going to first try to call them, and then are you going to try to text them? Are you going to contact a radio station to put out an emergency broadcast? Do you have walkie-talkies that you need to make sure are charged up all the time? That's a whole nother rabbit hole, but just know that your communications plan is extremely important. Training and testing, you must document that you train your staff on your emergency preparedness and that you test to see if it is working. I want to make sure that you guys see that it is required that you test. Testing is evaluation. Testing is data. In the testing, you have to evaluate, did everything go as planned? Was there any hiccups? Was there chaos? If something went wrong, why did it go wrong? If something went correctly and without a hitch, was it because everybody knew exactly what they needed to do? Everybody played their role? Was everybody present that needed to be? If somebody wasn't there that played a major role, do you need to now assign a backup person? And so evaluation is more than just looking at numbers. It is a deeper dive and finding out your whys. And here in a minute, I'm going to go into the 5 whys and more of the Lean Six Sigma type of approaches for evaluating things. But just know that there is a rhyme and a reason for everything that is being required of you. If you think of if something major does go wrong, like you get hit by a blizzard when you're it's 3 o'clock on a Thursday afternoon and you have patients being seen by providers and you have people coming in and people coming out. If something really goes wrong, what is going to happen? How do you know it's going to go well? How do you know that everybody that is on your staff knows the role that they play and what they need to do? It is by training and testing. And testing involves retesting. And retesting needs to be based on data. How are you going to improve? Now let's move into data-informed service lines. It's not just about your program evaluation and your emergency preparedness requirements and just maintaining your absolute necessities. Data-informed service lines can help you grow your business, can help you provide more services to your community and help take care of your rural community better, helping them become and remain more well. And here are just a few that I could think of off the top of my head: chronic care management, principal care management, transitional care management, and of course, the gold standard of patient-centered medical home. Here you can find a live link to the MLN booklet that is published by CMS to give you more information on chronic care and principal care management. Now, chances are a clinic is already doing parts of chronic care management, so why not formalize it? And you can actually get paid for the work that is being done. It's basically just keeping better tabs on patients to be able to prevent things from going wrong and help good things continue. And it's basically just following up outside of that face-to-face patient provider encounter. So having someone call and say, hey, did you pick up your prescription? How are you feeling now that you've been taking it for a few days? Do you have any questions? So on and so forth. And an FYI, if you are a patient-centered medical home, an accredited patient-centered medical home, you are already operating as a giant chronic care management model. And so using data to help inform your practice model will help better take care of your patients and help bring your clinic up to speed on the journey from volume to value by focusing on your population's health and by making evidence-based and data-driven decisions. Here you can find more information about transitional care management. And with transitional care management, it is basically bridging that gap between an inpatient experience back to outpatient. So, for example, say a patient got discharged from the hospital after some sort of illness or injury, and they've been instructed to follow up with their primary care provider. A lot of, I won't say a lot, but a handful, we'll go with a handful, I'm sure that's a real measurement, of patients fall through the cracks and they don't follow up with their primary care provider. And so CMS, and I'm sure other payers out there, will actually reimburse for transitional care management services. So they will reimburse a doctor's office for following up with the patient, because a handful of times patients don't always follow up with their primary care office. And so this is just, since you've been out from your inpatient hospital stay, have you had any hiccups? Have you re-injured yourself, or have you been compliant with your medication? And the main point of this service is to prevent readmission, because taking better care of your patients and keeping more tabs on them not only really takes care of them better and helps them stay more well, but it also saves payers money. Readmission into hospitals is extremely expensive, and catastrophic events where they're visiting back emergency departments, hopefully not multiple times, but it happens, is very expensive. And then also stabilizing a patient after those events is harder once they are repeat visitors to those more higher levels of care. And so the whole point of chronic care management, principal care management, transitional care management is to maintain a steady distance. It's a preventative measure. With a patient-centered medical home, here I have a link to NCQA, which is one of the bigger accreditation organizations, but there are a handful of other agencies that do the certification. So patient-centered medical home, or PCMH, is not a service line. It is a model of business, of practice operations. Not always, but some or most of the time, practice can renegotiate your reimbursement from some payers if you become a PCMH. And basically what this does is it shows the payers that you have elevated the services that you provide and the way that you operate and how you take care of your patients and your rural community. And so they are more inclined to offer you a higher reimbursement overall for your all practice, all service lines, because you're showing them that you are taking better care of their patients. And so, again, it's not all payers, but it's something that you can consider. And at this hot link that I have on the slide deck here, you're able to get more information about how it sorry, my brain just stopped for a second, how it allows you to improve patient care, but also improve your staff satisfaction. And so there has been some research lately on how, and again, data driven, how staff is more happy with how they are interacting with their patients, how their patients' healthcare is going, the care that they are able to provide themselves to their patients, and then also the team that they serve on every day at work. And it's been able to actually make a dent in recruitment and retention of healthcare providers. And so that is always a hot topic in our arena. So I definitely encourage y'all to check into patient-centered medical home. So now what? I gave you all this information about why data is so important, about how you have to evaluate your program and you have to collect data and you have to analyze data. But now what? What does this mean? I'm so glad you asked. So clinical application to everything that I've been saying. This slide should look familiar if you were with us on our last presentation. These are the low-hanging fruit that I was able to pull from to start your journey. And it is, and again, I'm not clinical. And so if this is something that's not applicable to your practice, then please feel free to get another quality indicator that is more applicable to your practice. But here are the ones that I thought were the low-hanging fruit that you could more easily gather data on to be able to analyze. And so it's pretty standard operating procedure that every patient gets their blood pressure and their weight recorded at each visit. And so this is the perfect, in my opinion, the perfect quality indicator that you can start your journey with. It's standard, everybody gets it, it's recorded, you're able to see if anything is trending up or down, and if any sort of medication is making any sort of dent in how that is going. So blood pressure medication, there's different weight medication, there's different illnesses that are diagnosed that could impact this measurement. And so definitely something that is a lower hanging fruit that you keep tabs on. Let's see here. These are all live links to the quality indicators. So you can check it out to see what they're all about. I'm not going to go too much into detail on them. But if you would like a more in-depth quality focused program evaluation template, I have it hot linked right here. This is to our website. We made this template back in 2016, but it's still very relevant to what you can start your journey with. Again, very low hanging fruit. You don't need to go to the deep end of the pool when you are starting a quality journey, but this will help you on your way with this template. Now, operational. I know I've focused more on operational, but that was on purpose. And so I feel like, especially in healthcare, we are highly focused on the quality indicators of the patient care itself. But there are a whole nother side to the business of healthcare, and that is workflows and staff issues and policies, procedures, so on and so forth. And so again, I recommend picking that low-hanging fruit, especially when you're just beginning the journey. And some potential ideas for dipping your toes into non-clinical data is, for example, compare your annual cost reports. Are there any trends, discrepancies, outliers? Were you really satisfied with your data in a particular area, but maybe you haven't hit those numbers since a certain time? Can you dig a little deeper into it? So what happened? Try to identify the why. Were there provider or staff changes? Were there reimbursement changes? System restructuring? More or less local competition? New or fewer service lines offered to your patients? Did a large employer in the community leave or enter, and that affected your population size? Was there a global pandemic that literally shut down the entire world for quite some time? It's important to not just look at numbers, but try to identify what a root cause of those numbers are. And another thing that we can look at is, are there errors occurring in any of your workflows? Write down what is happening. So, for example, let me just pull one out of the air real quick. Patients' records aren't being completed and signed off on in a timely fashion that is dictated by your policy, like within so many days or hours of the patient visit. Write down what's happening. Where is the error occurring? When? Who is responsible for aspects of that workflow? And then how much is that error happening? These are all different ways that you can try to dig further into what is going on. And then also there's ways that you can investigate more. So there's the 5 whys, or a fishbone diagram, which I'll show you here in a second, for what is causing the error. You can create a mini plan, do, act study. Again, I'll show you that here in a minute. Nothing really needs to be super complicated. In fact, I love the old KISS strategy of keep it simple, sweetheart. So if you don't need to make something complicated, let's not make it complicated. Everything changes, and therefore things may need to be looked at again and tweaked. These need to be regular standard operating practices in your practice, because when we know better, we do better. Here at the bottom of this slide, I have a link for the American Society for Quality, and this is the thing that I wanted to show you. Let me pull up this website real quick. And again, my favorite thing in life is free. And so, especially when it's a free resource, here we go. Pull it onto my screen here. So this is the quality site that I just told you about. The hot link brings you to this landing page. And the reason I recommend this so much is because it doesn't just give you templates, it gives you definitions, it gives you education. And so you have quality tools here in an index form, which is awesome. Here it tells you what it is. So you have different check sheets. You have templates for it. Here is, where was I going? Fishbone diagram. So for a fishbone diagram, it tells you exactly what it is. And then it tells you how to use it. It tells you what it's for. It gives you an example of one completed. And then when you go back, oh wait, here's another diagram. When you go back to this, you're able to see the template and it gives you exactly what you need. Let's see here. There we go. And this is again, find that cause and effect, that root cause. Why is this problem occurring? And it helps you, it helps guide the conversation. It helps guides the brainstorming, and it is able to get to that root cause. And so here we go. Of course, you need to save your own copy. It's read only. Here we go. So this is super cool. Not only does it give you the template, it gives you the instructions, it gives you hot links to learn about the different diagrams that it has, and more resources. And like, it's free. How cool is that? It has on this tab where you're able to go to the source and get more information if need be. And then here it gives you the spaces to add your data, your prompts. So it's just an awesome template. I wanted to make sure that I show it to you guys. So back on here, there's a dime a dozen things that you can find for Lean Six Sigma, which is basically quality improvement. And so I encourage you, when you have your free time, of course, when you're not taking care of your patients, just explore this page here, find out the different kinds of flowcharts and the templates that there are, the plan, do, act, study cycle here. If you don't have to reinvent the wheel, please don't. There are resources and templates out there for you. And I tried to find one of the better sites that are able to share their resources with you for free. And so all you have to do is click and find what works best for you. Again, I love that they have the definitions and how you can bring it into your own practice. And so just wanted to share that. And that is what this hot link is. Now I want to bring it all together. Just pause for a moment. I told you at the beginning that I was going to be taking a big journey into a lot of information. And you guys have probably already put everything in place and together, but just in case, I wanted to pause for a minute and bring it all together. So continuous quality improvement and performance management is basically just a data-driven way to ask ourselves, what can we do better? How can we streamline and optimize a process or a workflow? How can we communicate better? How can we save money? And even how can we improve workforce recruitment and retention? But most importantly, how can we better take care of our rural patients and help them become more well? By asking ourselves these questions and analyzing the data, We are purposefully focusing on our population's health and making the necessary steps in the journey of moving from volume to value in healthcare. And so this is our see the forest for the trees moment, where everything comes together. It's important to note that when we are asking ourselves these questions, that we always have in mind that it is always about the patients and how can we serve them better? How can we help them on their health journey? Of course, we can't make anybody do anything, but we can do everything on our parts to help them understand how they can make that journey easier for themselves. And by virtue of just being there, it makes it easier on everybody when we work together. And that's a huge part of the communication piece. So having that said, when you see this slide now, does it look a little different when I say documentation? Excuse me, documentation is the cornerstone of the business. I just want to give you a second to reflect on that. Because again, documentation, like my teenage niece would say, is everything. Data and documentation is everything. So here I have some more resources. I'm all about resources and free templates and free information as much as possible. And so I have a few slides of those. But I want to make sure that I thank you to Kiona and the Rural Health Provider Transition Project for allowing NoSOR to present today. I really appreciate the opportunity to spread the good word of data, especially because I am a data nerd. It's what I do. Are there any questions that I can help you guys with today?
While we open it up for questions, please feel free to use the chat box or unmute your line to ask Tani anything. And I'm going to pull up the polling questions so that we can launch those at the same time. Tani, I think the resources that you shared were absolutely wonderful. And I just want our participants to know that within the playback, we will be sharing the slide deck that has the links, and you will have access, quick access to those as well.
Perfect. Thank you for that.
Mm-hmm.
And then also at the end of the slide deck here, my contact information. So if you are exploring the resources and you happen to come up with questions later, please feel free to reach out. I'm here to help. I am the technical assistance manager, so it's what I do. But also if you want to get in touch with your local state SOAR, State Office of Rural Health, please feel free to check out our website as well, and you can get that contact information. But happy to answer any questions now if we have them. Any questions in chat here? Oh, thank you, Rhonda. That's very kind of you. I appreciate that.
Well, with no questions popping up, I'll wrap us up for today. So thank you, Tani, for like Rhonda, I'm just going to reiterate what Rhonda had shared. Thank you for sharing your expertise with us today, but also through this series. If this is your first one attending, it is This is part 3 of a 3-part series, so there are 2 other available playbacks. The recording of today's help webinar will be available within 5 business days on our help webinar landing page on our website. As a reminder, if you would like 1 ACHE qualified credit for today's attending today's webinar, you will have to complete the short online assessment that will be sent out immediately following today's webinar. With that, we encourage you to reach out to RIPT with any TA questions that you might have. And thank you again for all of your, to all of you for your participation in today's event. Have a great rest of your day.
Thanks, y'all. Have a great day.